I'm going to go ahead and lecture on Chapter 15, Medical Overview. You'll find this information for the National EMS Education Standard Competencies in the very first page of the chapter in your textbook. This is where they're going to go ahead and get your FISDAP questions from, your NREMT questions. We're going to learn about how to assess a patient when they've got a medical problem, how to treat them. We're going to learn how to decide about transport mode and destination decisions. We're going to become aware of infectious diseases. We're going to learn how to help prevent it, how we can help determine if our patient does have something that may be infectious. In EMS, we have our patients who are calling us. A lot of times they're having a medical emergency. They may be having a traumatic emergency. Sometimes it could be both. Motor vehicle accident, the patient has a heart attack. Which one caused which? Did the heart attack cause the motor vehicle accident, or is it a result of the motor vehicle accident? So we need to kind of try and figure out what's going on with our patient, not necessarily what order it occurred in, but what is going on with it. With trauma, it's going to be an injury that has occurred from an external force involving the body. Okay, striking a tree with your car and then your body strikes the inside of the car, or a fall from a height are examples of trauma. And we have our medical emergencies, lung problems, respiratory issues such as asthma, pneumonia, COPD, emphysema would be some examples. Cardiac issues such as congestive heart failure is another example. For our respiratory emergencies, our patients are having a difficult time breathing, or they are breathing adequately, but the oxygen is not being used appropriately by the body. It's not getting adequate oxygenation to the tissues. With cardiovascular, it's something involving the circulatory system. Neurologic is going to involve the brain. Gastrointestinal disorders can include appendicitis, diverticulitis, pancreatitis. A multitude of other illnesses can be involved, gastroenteritis. We've got our urologic emergencies. Generally, that's going to be kidney stones. Your endocrine, most common one that we're going to see is diabetes. With your hematologic emergencies, we're going to be talking about sickle cell anemia or hemophilia, which is a blood clotting disorder. Immunologic, we're talking about severe allergic reactions going into anaphylactic shock. Toxicologic is poisonings, substance abuse, overdoses. We've got our psychological and behavioral issues, and then we have our gynecologic, which involve the female reproductive system. So here on table 15-1 is some common medical emergencies. I'm not going to sit there and read this to you. You can see it and go ahead and read it. These are some types of emergencies that we may come across and have to deal with. We talk about our patient assessment. We're going to do that head to toe. If they're unconscious, if there is a specific complaint, we can do a focus exam. With this particular situation, we're going to be talking about nature of illness because it's our medical. We're dealing with nature of illness. They're going to be sick. What are their symptoms? What are their chief complaints? We want to get a really good history to the best of our ability to figure out what's going on with them. Dispatch information, it's as good as what dispatch is told. Okay, if they're told that, Grandpa fell on the floor, they're asked, is he still breathing? And they say yes. You walk in thinking it's just a lift assist and grandpa's in cardiac arrest. It could be that what the patient or the family member thought was breathing was actually agonal gas. So you need to keep that in mind, that that could be an issue. You're only as good as what you're told. So let it guide you, but don't get tunnel vision thinking that's what it's going to be. If your patient is hostile or uncooperative, it may be difficult to get your history or to do an assessment. Be professional, calm. We never judge at any point in time. We don't know what's put this patient into this position, so it's not our place to judge them for being there. Don't label them. Oh, they're a drug addict. Oh, they're a frequent flyer. They're seeking. We don't do that. That's not appropriate. It's not in our patient's best interest. If we have a patient that calls on a routine basis, I've got a headache, I've got a headache, I've got a headache, and they call and say that every time. Most times it is a headache, but what if this time it's a stroke or a brain bleed? Okay, or what if they're calling because they've got something completely different going on, and we take our time going to the truck to get in or out to see this patient, and we have something totally different going on, and we're running the risk of causing them further harm by delaying our transport. We get on scene, always scene safety. You want to make sure that when you roll up there, you're checking to see what's going on. What kind of PPE do I need? How many patients do I need? Do I need additional resources? If I do, what additional resources do I need? We're going to assume that it's an NOI just for right now because we're dealing with medical. When we're looking at it, look at the patient. How are they lying? How are they sitting? Do I need to worry about holding C-spine? Maybe it is a medical problem, but maybe they fell as a result of that medical problem, or maybe the medical problem is a result of that fall. So always consider C-spine. Do I need to handle it? Do I need to have it stabilized? Get your general impression. As you're walking up to your patient, you're looking at them. You're seeing what they look like. Are they looking at me? Are they responding to me? What's their level of consciousness? Hi, my name is. Introduce yourself. As you're introducing yourself, if they reached out to go ahead and shake your hand, shake their hand, check their pulse. See what their skin feels like. Is their pulse too fast, too slow? You can get a lot of information in just a few seconds by doing this. How are they breathing? Is it too fast? Is it too slow? Is it not at all? Is it noisy breathing? Is it adequate? Is it regular rate, regular rhythm? Do I need to put oxygen on? Do they appear to be having difficulty? If they're unconscious, is their airway open? Do I need to do something to correct it? When we're putting oxygen on patients, if they're in shock, if they're having difficulty breathing, when their O2 sats are low, if they're measured, these are ones that we definitely want to put on oxygen, but we never withhold oxygen from any patient if they need it. Okay? If they need it, they can have it. If their SpO2 is less than 94%, they're definitely going to be put on it. When we're looking at our unconscious patients, do they need an airway adjunct? Do they need that OPA or NPA to keep that airway open while we're doing a BBM on them? What's my circulation? We just talked about that a couple of minutes ago. When I'm shaking my patient's hand, I can be checking their pulse. I can feel their skin. I can see what it looks like, what the color is. Does it look like it's sweaty? If we've got an unconscious patient, we're going to check their carotid pulse. Remember, we don't want to check it this way because it looks like we're choking our patient. we want to check it on the side that we are on to make sure that it is present, and how is it. Depending on how my patient's presenting, is going to tell me how fast I need to get them in the truck and get them en route to the hospital. Are they unconscious? Are they altered? Is there any kind of airway or breathing problems? Do they have severe bleeding, signs of shock, circulation problems? If so, we're going to get them loaded up as quickly as we possibly can and get them transported into the appropriate facility. Next step is, once we've done all that, we're going to go ahead and get our history. We want to get as thorough of a history as we can. Now, I don't mean that if I have a 70-year-old lady who's got chest pain and I start asking what kind of medical history she has, and she goes on to tell me about a tooth that she had removed when she was 4 or 5 years old, I don't need to worry about that. That is not pertinent. I want that pertinent past medical history. Do you have a history of heart problems? Do you have a history of lung problems? Kind of guide her back around, or guide your patient back around to get that information that you need. If they're unconscious, look to see if there's any medical containers or any medical devices. See if there's a family member or a friend that knows their medical history that you can talk to and get that information. The more information we have, the better it is for the hospital to be able to treat this patient appropriately. You're going to get your sample and OPQRST. You're going to make sure that you've got your allergies listed, any medical conditions, your medications. If there's a bunch of medications, you can take them to the hospital with you. Just be cautious that you know that it's left with your patient so that it doesn't get misplaced. When we're doing our secondary assessment, sometimes we're able to do it on scene, sometimes we're doing it in the back of the truck, sometimes we're not going to be able to get it done at all. It depends on what's going on. So you're going to go ahead and do your head to toe or your focused exam. Depends on what you need. If it's an unconscious patient, you're always going to do a head to toe assessment. We're looking to see if anything has changed, anything's improved. We can do our head, scalp, and face when we're doing our head to toe. We're looking for any kind of bruising, abrasions, crepitus, decap, BTLS, deformities, anything that's abnormal, we're going to want to go ahead and make a note of. You're going to check your neck, front and back. You're looking to make sure your trachea is midline, you don't have any JVD, that your cervical spine doesn't have any step-offs or displacements. You're going to listen to your lung sounds front and back. You're going to palpate your chest. You're going to go ahead, palpate your abdomen. Go down both legs, both arms. Roll your patient to their side. Check the back, the buttocks, and the back of the legs, looking for any kind of abnormalities. We're going to get our vital signs. We want our pulse. We're looking for rate, quality, regularity. You want to know your respirations, rate, rhythm, and quality. Your blood pressure. First blood pressure is always supposed to be a manual blood pressure. Okay. If they're altered or unresponsive, always get a blood sugar. Get a pulse ox. Monitor those vital signs. Once we've completed our head to toe, we've started treating, we're going to reassess. Where do we start our reassessment at? You're going to start back at your general impression. Go all the way back down that sheet again. Okay. The reason we're starting at our general impression is, what's my patient look like? What has changed with my patient? So that's how we're going to start it. We can think about calling out our ALS unit if it's a problem that needs more advanced medical treatment than we can provide. You're going to be reassessing my interventions. I'm looking to see if it's made the patient better, made them worse, or it's had no change. That's what I'm looking for when I reassess my interventions. Anything that's changed, I'm going to be documenting. If my patient is stable, I'm going to reassess them every 15 minutes. If they are unstable, we're going to reassess them every 5 minutes. Where am I going to take my patient? It's going to depend on their situation. I'm going to take them to the closest, most appropriate facility. If they're having a cardiac issue, I want to take them to a cardiac facility. If they are trauma, they're going to a trauma center. If it's pediatrics, pediatrics. So I want to get them to the most appropriate facility. You don't want to be on scene any longer than you have to, but you want to make sure that you're treating everything that you need to treat appropriately before you start transporting. You want to get as much information as you can so that you can let the hospital know when we get there. If it's a critical patient, we're going to be doing a rapid transport. We don't want to stay and play. We want to load and go. So if it's a life-threatening condition, heart attack, a stroke, severe trauma, we're going lights and sirens. Okay. If it's non-life-threatening, we can consider doing a non-emergent transport. If I need to transport somebody for a life-threatening, I can consider go ahead and having a helicopter come in and fly them out. Or I could transport by ground based on weather conditions, distance, traffic conditions. So with the ground units, normally we have EMTs or EMT and paramedic. Some departments have paramedics. We've got our air transport. They're going to be critical care medics, nurses, flight nurses are going to be on the helicopters. Again, where am I taking my patient? The closest, most appropriate hospital, depending on their condition. Let's talk a little bit about infectious diseases. How do we treat the patient that has something that is infectious? You're going to treat them just like any other patient. You're going to make sure you've got your scene size up. You're going to wear appropriate PPE. You're going to do your primary assessment. You're going to get history, OPQRST, find out how long the patient's been sick, what kind of an illness they've had. You're going to get your sample, your basic vital signs. You can ask them, have they recently traveled, or if they've been in contact with anybody who has recently traveled. Kind of gives you a little bit better idea as to what you might be dealing with. You're going to focus on your life threats in your primary assessment. Always, always be empathetic to your patient. You're going to put them in a position of comfort, keep them warm, use your standard precautions, following your department's protocol to clean the equipment afterwards. So what is an epidemic? An epidemic is new cases of a disease in a human population substantially exceed what is expected. Pandemic is a disease outbreak that occurs on a global scale. You need to know these definitions. You will see them again. So some examples. We've got the flu, influenza. People who have chronic medical conditions, compromised immune system, the very young, very old, are most susceptible to complications of influenza. What are some of the complications? Can be, severe respiratory distress, potentially leading up to pneumonia. So we've got, it is transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by infected people. It's a disease that can be passed by the respiratory route, so you're going to make sure you've got your PPE. PPE in these cases is going to be gloves, eye protection, HEPA, or an N95 mask. You're going to put a surgical mask on the patient with the suspected disease. Okay. It is recommended that you get your flu shot once a year to help you from getting the flu. So herpes simplex is a common virus. It's carried by humans. It has vesicles that appear on the lips or genitals, like blisters type things, little sores. Can cause a more serious illness in susceptible patients, such as pneumonia, meningitis. Again, this is in the very young, the very old, and the immunocompromised patients. It's generally passed through close personal contact. Using standard precautions are usually going to be sufficient to keep you from getting it. HIV, we are going to deal with HIV patients and AIDS patients. You will come across them. You're going to make sure that you use proper PPE. AIDS is fatal still, but with treatment, our patients have a near normal lifespan. It's not as easy to get as you think. Does not mean, though, that we should be careless. You always want to make sure that you're using proper PPE, that you are handling the sharps in the appropriate manner. Don't go picking them up in a manner where you get poked. Make sure that we're disposing of them properly. Limit your exposure to the blood and bodily fluids. A lot of times people with HIV do not show symptoms, so you're still going to make sure we've got our gloves. Caution when we're getting rid of our needles and sharps. If there's open wounds, you want to make sure that they're covered before you come into work. You know, if you've got an open sore, cover it up. Just minimize that risk of infection. If you think that you may have been exposed, you're going to seek medical advice and you're going to notify your infectious disease officer. So with hepatitis, it's inflammation and often infection of the liver. It can be caused by viruses, by toxins. You don't know if they're contagious or not if they have hepatitis. You can get the hepatitis B vaccine. They recommend it very strongly for EMTs and paramedics. This chart here, table 15-2, goes over the different types of hepatitis, how you get infected with them, the incubation period, chronic infection, vaccines or treatments, and comments. I am not going to sit there and read that to you. I'm going to let you go ahead and do that yourself. Again, that's table 15-2. With meningitis, it's an inflammation of the meninges. The meninges covers our brain and our spinal cord. All right, it's a protective layer. Usually meningitis isn't going to, well, most forms of meningitis aren't going to be contagious, but meningococcal meningitis is extremely contagious. It's a bacterial infection. You can have antibiotics will treat it. You're going to use your standard precautions. After you have a meningitis patient, you're going to be contacted by, actually your employer is going to be contacted by the hospital to tell you that you've been exposed to meningitis, and they recommend you start a course of antibiotics. All right, we can minimize our risks by using proper PPE. They don't generally use the vaccines. Okay, there are vaccines, but they're not common. So with TB, tuberculosis, most of the time the infected patients are well, they're not ill. When we have chronic mycobacterial disease, it's usually going to be in the lungs. It's going to shortly after exposure, you can develop an illness. It's going to be Primary tuberculosis is what they call it. Then we have reactive tuberculosis that's going to be more difficult to treat. We have the patients that are highest at risk. Usually you're going to have a cough. You want to put on that N95 or the HEPA mask on yourself, surgical mask on your patient, in order to help prevent it from being spread to you. There is no absolute protection. About 1/3 of the world's population is infected with tuberculosis. The mechanism of transmission is not very efficient, however. So it's recommended that once a year you get your TB skin test. If the infection's found before you become sick, preventative therapy is almost 100% effective. So we're going to talk about whooping cough. It's called pertussis. Usually we're going to see it in children who are under 6 years old. They're going to have a fever and they're going to have coughing jags, coughing attacks, coughing spells or fits, whatever you want to call it. At the end of that, because they've been coughing for so long, they take a big deep breath that makes a whooping noise as they're inhaling, and that's where it gets its name. The best way to prevent it is to have your DPT or your Tdap. And your Tdap you should get every 10 years. Put a mask on your patient and yourself to help reduce that infection. When we're talking about MRSA, methicillin-resistant Staphylococcus aureus, it's a bacteria. It is resistant to many antibiotics. There are some that will treat it, but there's more that don't treat it. Usually it's going to be transmitted from patient to patient because the healthcare provider didn't wash their hands in the hospital setting. Washing your hands is one of the most effective ways to keep us from getting sick, right? So some of the risks to developing MRSA is antibiotic therapy, prolonged hospital stays, staying in an intensive care or a burn unit, or exposure to an infected patient. Incubation period can be between 5 and 45 days. It is soft tissue infections. You're going to have localized skin abscesses. Our older patients may develop sepsis as a result. COVID-19 came out of China, became a pandemic. You have fever, cough, shortness of breath, 2 to 14 days after exposure. And we have MERS, Middle East Respiratory Syndrome coronavirus. First human case was in 2012 in Saudi Arabia. Most of the infections in humans are found in the Middle East. There have been some cases in Europe and the United States, however. If you suspect it, you're going to put a surgical mask on the patient. You're going to let the hospital know that you suspect that you're bringing in a MERS. With Ebola, we had an outbreak in 2014 in West Africa. It spread when infected people traveled to other countries, caused an international concern. Generally, incubation is 6 to 12 days after exposure, but it may take as long as 21 days for symptoms to appear after you were infected. Fatality rate can be as high as 70% if treatment in an ICU is not initiated promptly. If you suspect your patient's been exposed to Ebola, you want a surgical mask on the patient, proper PPE as outlined by your protocols and the CDC. Definitely notify the receiving facility. So when we have people traveling, there's infections that they can develop from other countries, okay? When they've recently traveled, you want to find out where did they go, when did they go, is anybody else in their party sick? You want to know what type of symptoms they have. Do they have fever, cough, vomiting, bloody diarrhea, body aches, rashes? If they've been traveling recently and they're ill, go ahead and put a mask on them and a mask on yourself. Get as much information as you can so that you can give it to the hospital. Some of the questions you're going to ask is, where did you recently travel? Did you receive any vaccines? Were you exposed to any infectious diseases? Anyone else in your party sick? What type of foods did you eat? What kind of water did you drink? Think about it. If we go to another country, we drink bottled water and then we pour it into a glass of ice. Or we drink canned soda and you pour it into a glass of ice. You're drinking their water because of the ice. All right, so you want to think about that. If you suspect they may have a communicable disease, you're going to follow your protocol as far as your proper PPE, and you want to let the hospital know. So basically, this chapter is telling you that assessment and treatment of medical patients is challenging. We have to almost be a detective, okay? The medical patient might not have signs and symptoms like you see in a trauma patient where, you walk up and you see that bleeding. You have to ask questions. You've got to investigate a little bit more with the medical patient in order to figure out what's going on with them. You never want to delay transport to try and figure out what the diagnosis is, okay? That can cause further harm to your patient. You don't want to do that. You always want to remain calm, use your assessment skills, treat your patient's symptoms, let the medical control know what's going on. When you're en route to the hospital, you're going to call the hospital and tell them what you have. Be ready to handle any kind of problems. And if you have a medical patient that's also a trauma patient, you need to be aware that you may be dealing with both and need to treat both types of symptoms. If you have any questions, please feel free to ask when we're in class next, and have a wonderful night.